So welcome to the first of our three sessions together. And, the overall topic is environmental health, but there's another term I like to use, communitology, to really describe the approach that we use in this field, which encompasses public health and community health and environmental health, because they have a lot of overlap in the Venn diagram. The middle, the intersection, is really about acknowledging that health happens in communities. Disease is treated in hospitals. But if we really want to get to the root of health disparities, we have to be working in the community space. So this communitology is maybe a reminder about that principle. And we're going to talk a little bit about how that might be put into practice as we go through this first session, which is focused on sort of the public health underpinnings of the work we do. So here's the hypothetical kid with asthma. And you had some time to think about, why this kid has asthma. So what are some of the things you came up with? Why does this kid have asthma compared to another kid who just doesn't have asthma? What are some of the possible reasons? Oh, you know what? And before you give your answers, I should set the tone by saying that this is not rounds. So it doesn't have to be a correct answer. It doesn't even have to be a realistic answer. It can be speculative. It can be imaginative. So I'll throw out the most obvious answer, which is that the Illuminati has a dastardly, insidious plan to release nanoparticles that target the lungs of children to induce asthma, because you can connect the dots yourself, but that leads to their total control over the human society. So I threw that out there so you don't have to, but why else might this kid have asthma?
Like the house he lives in is dirty or dusty, and there's like environmental pollutants there.
So dirty or dusty, let's be, yes, I'm going to say, with this, like improv comedy, we're going to say yes and to everything, but give me a little more clarification on like which. So dust could be an irritant in the house. Did you want to parse out some of those other things?
Um, I mean, I guess if there's just like a lot of people in the house, or there's like mold, or just like all these things in like houses, can like cause kids to have like worse asthma, I guess.
Sure. Okay. And then you mentioned a lot of people in the house. Where are you going with that thought? It's
Um,
intriguing.
I guess I guess just like if there's multiple people in the house, like more likely that people will like share illnesses, and like illnesses can like exacerbate asthma.
Okay. So infectious disease.
There could also be
Okay.
smokers in the house, which could trigger.
Smokers. Yep. I should say smoke exposure. Yep.
Another one for like a housing issue would be like bug infestations.
Yep. And do you know how that relates to asthma? What's the mechanism there?
I just know that like particularly with roaches that like that can cause like asthma triggers. I'm not really sure exactly why.
Yeah, and it's really I hope I don't misspeak here, but I believe the term is frass. Frass. It refers to basically cockroach poop, which is an allergen for. So it's not the cockroach, it's the cockroach poop, but yes. So cockroach exposure is associated with asthma symptoms in those who are allergically sensitive. Yep. What else? Why might this kid have the asthma?
I mean, if this kid has other comorbidities like food allergies or eczema, that puts him at a greater risk.
Okay.
It's like the area.
Sorry, I just want to mention. Oh, first of all, is it Sarah or Sarah?
Sarah.
Sarah. So Sarah, are you thinking about like an atopic profile, basically?
Yeah.
Okay. A to P. Okay. Sorry, go ahead, Chris.
I was just saying, like, if the like area he lives in is like polluted, like if there's like
Okay.
factories nearby
Okay.
or stuff like that.
So we'll call it outdoor air pollution. And it could be from, industrial sources, let's say. Okay.
I know a lot of times like some of these older schools in like worse areas have like, you know, similar things like the home, like dust or mold.
Okay, so we can talk about what's going on in the school environment.
Weight affects asthma,
Okay.
like poor access to healthy food, lack of like funding for food, or like not having access to outdoor activities or safety going outside.
Okay, so you started with this idea of obesity as being a comorbidity, and obesity by itself can exacerbate asthma, but you also started sort of unraveling what's behind that. There's more than just the obesity itself. Why is the obesity there, and is that linked to the asthma? So that's a great place to leave off, because we can sort of pick up on those threads as we go through some of this other content. Now, do any of you have a public health background? Do you have an MPH, or have you taken public health courses? Even if you don't, I'm wondering if you've heard this story before, this parable of the drowning child. We're going to go through it now. And even if you've heard it before, that's okay. Because it always sort of brings new insight whenever I go through it in my head. So the most implausible part of the story is that you have to imagine a day when you have no obligations. You really have absolutely nothing that you're supposed to be doing. There are no tests you're studying for. There's no charting you have to catch up on. You don't have to do your taxes, like absolutely nothing. You've got a completely free day. It happens to be a nice day outside. You happen to live near a wooded area with a stream running through it, and you decide to go for a walk. So you're walking along the bank of the let's say it's a small river, and your quietude is disrupted when you hear a splashing and a thrashing, and you look to the side, and there's a child in obvious distress. So without overthinking it, and this is not a course in water safety, but what do you do?
First, you would probably try to get the child out of the water.
So somehow it sounds like you're implying that we should rescue the child who's in obvious distress. So let's just, for the sake of argument, say that the water's shallow near the shore, and you find a long branch, and you're able to wade in without jeopardizing your own safety and hold the branch out, and the child grabs a hold, and you pull the child to shore. Now, out of nowhere, the child's parent comes running up to you and says, "I lost track of my child. Oh my gosh, you just saved my kid." And there was another bystander who, out of nowhere, happened to have been standing by and had videoed the whole thing. And that night it goes viral, and you're on the local news. Wow, this is really something you didn't expect when you went out for this quiet walk. And the child and the parent go on their way. The bystander departs, and you continue on your walk. And all of that adrenaline and cortisol is washing out of your system. And you're starting to enjoy the day again, when there's another splashing and a thrashing, and you look to the side, there's another kid. So again, I ask the question, what do you do?
Rescue this kid too.
So Sarah says, if it's not broke, don't fix it. It worked the first time. Let's do the same thing. So you wade into the river, you hold out your branch, you pull the kid to safety. And, even in the practice of medicine, in pediatrics in particular, it's rare that we save a life so directly. And here you are on your day off, and you've just saved 2 children's lives, and you're feeling a sense of, excitement, perhaps perhaps relief that you didn't decide to stay home and just binge watch a show you wanted to catch up on. You really served a purpose coming out here today. And you're thinking about this sort of philosophical approach to life as you continue on your walk, and you can imagine what happens next. There's another splashing and a thrashing. So we're going to make the assumption that you decide to save this child too. What else might be going on in your head in terms of a question you might have at this point?
I might be wondering if the Illuminati kidnapped a lot of parents and is plotting to take down children.
I think that's the first thought we all thought of. Yeah, thanks for saying the obvious. Yeah, and even more broadly speaking, you know, why are all these kids in the water? So here you are, pulling that third child out of the water. And as you're doing so, you sort of glance out there into the water and you see there's another kid on the way, and you lean even further. You're like, is there another kid? How many kids are there? So the next question is, why, right? And again, I'll set the tone and say the obvious reason all these kids are in the water is because of that alien base on the dark side of the moon that's using mind control to compel all human children to seek water and drown themselves in their slow but sure attempt to conquer the human race. But why else might these kids be in the water? You know, we're creating something of a differential here. We know we have drowning children. That's the chief complaint, as it were. But why are these kids in the water?
Maybe there's like no fence around the river and there like should be.
No fence. And is there any reason why they're even near the water?
They just like don't have access to like green space at where they live, so they have to go to a park.
And only place to play outside. Yes, and
Maybe all of the kids live near the water.
live nearby. And are you going with the no fence hypothesis again? Or is there something else?
Yeah, like they live nearby. Maybe that today was a planned event, like in this area, and there wasn't adequate like safety measures in place.
Got it. Yes, and
Like maybe parents are busy working. There's like no one to watch the kids, so kids like go to the park by themselves and like no one's supervising them.
yes, and
Maybe they were all given like floating devices that failed.
failure of water flotation devices. Yep.
Maybe they thought they knew how to swim, but didn't actually.
Overconfidence. Have you guys heard of the Dunning-Kruger effect, by the way? Just a trivia. Chris, you're nodding your head a little bit.
Yeah, it's like when it's like a bell curve of like when you don't know something, and then in the middle of the curve you like know enough to where you're like confident, and you like realize at the end of the bell curve like you know so much that you actually don't know like anything at all.
Yeah, basically, the more you actually do know, if you're an expert on a topic, the less confident you are of, you know, answering a question on the topic. And at the other end, if you don't know anything about the topic, you feel very confident answering the question, thinking that you're right. So maybe there was some overconfidence involved here. Oh, I don't know how to swim, but I'm sure I can. Let's just jump in. So why else? Anything else come to mind? Why are these kids in the water? Besides the mind control plot from the aliens.
Maybe like there's no like pools around and it's like hot out, so they want to go in the water.
So we got to talk about climate change. Climate change compels them to seek water. Yep. How about one more?
Maybe like they're bored, there's nothing else to do, so they want to go swimming.
Purely bored. Why not? Let's just jump in the water. Okay, so we have this differential. And you're here, like I said, pulling that third child out of the water. You've got this list in your head. What do you want to do about it? How can we find the real answer?
You have to probably talk to the parents and the kids, like kind of get demographic information,
Oh, okay.
find out like what happened.
It sounds like you're approaching it like an epidemiologist. Yeah. And again, for the sake of argument, we're going to put a constraint in that all of the children who have already been rescued have left the scene. Same with the parents. There's no other bystander at this point. And the child who you are in the process of rescuing is in no position to answer questions. Let's say they've lost consciousness. So what else could you do to find out the real reason why all these kids are in the water? And I'll suggest something. It's a leading question. This is a river, not a lake. So it's moving water.
Guess you could follow upstream to the
Upstream.
source.
Caitlin, you said the magic word upstream, right? So here you are downstream, rescuing the children who are already in trouble. But we don't know what's going on upstream. Okay, so what happens if you decide to head upstream to find out the source? What would happen to all the kids downstream?
Probably do something preventative to stop there from being more downstream cases.
Yeah, so that's your intent, right? This has to stop. So I'm going to head upstream, find the source, and intervene. But what happens to all the kids who are already in the river now that you've left your post downstream?
They drown.
They drown. Okay, so that sounds like a problem. What if we stay downstream to keep rescuing these kids?
You just have to keep rescuing them because there's nothing preventative being done.
And you're going to fatigue. You're going to put yourself in danger. Some of these kids may be out of reach from your trusted hold out the branch method. Some of them will have already drowned by the time they reach you. So this is a dilemma, right? Two bad choices. So there are two messages I like to emphasize in this parable. One is that there is an upstream and a downstream, right? Here we are dealing with the consequence of some cause. We're downstream. But the problem is not happening downstream. The problem is happening upstream. And the second message is that there's a false dichotomy here. That we have to be heroes rescuing drowning children while somebody else needs to be responsible for the root causes. So let's imagine that the truth in the story is that there's a bridge that's broken and the kids all live on this side of the river, but they go to school on this side of the river, and this is the only way to cross the river. We've just designed a drowning child system. We should not be surprised that there are drowning children. We've built this system to produce drowning children, essentially. And this is what we typically, this is how we typically divide clinical care versus public health. So as physicians, we're trained to, analogously treat the drowning children, while public health people are supposed to be fixing those bridges. But it's really a spectrum, right? We need partners all along the way to do what they can to intervene at these different levels. Because the burden can't be on us. The entire burden can't be on us, because we're not going to save all those children, especially if you think about the ethics of it. These drownings are preventable. So why wouldn't we spend more of our resources upstream and work together to maximize the prevention? And then, of course, there always will be cases that occur, but at a much lower rate. And then we can more effectively dedicate resources to saving those kids who are in trouble. You might be thinking of, your current situation as trainees. And let's add a little illustration here to talk about the bigger picture. This is always a bit of a challenge drawing with a trackpad. Let's see how this goes. Oh, well, there we go. That's the challenge right there. All right, so basically we have a system that's designed in this country for rescuing drowning children. So you all are training with Northwell, and let's talk about the greater New York City area. Who are some of the other players down here figuratively rescuing drowning children? Northwell, and who else?
Like the other hospitals, you mean, or just like NYU, Mount Sinai, New York
Yep.
Presbyterian,
Yep. How about if you're up in the Bronx?
like Jacoby.
Sure. Or Monty is the biggest one, I believe. Just curious, have you folks started receiving your subscription to Pediatrics, the journal? A couple head nods. So have you opened one up yet? Have you looked at one? Or are they just sitting in plastic wrappers somewhere?
I spent one during my vacation.
Right. Do any of you have a copy nearby? Perhaps?
I might. Hold on.
You want to take a minute to look? And then I'm going to pull up a photo I took on my phone this very morning. I don't know how well this is going to work. I didn't have time to upload it. Okay, there we go. Found it? Okay, so is it still in the wrapper?
This one was, yes.
Okay. And is there a sort of insert stuck to the cover with that weird like sticky stuff?
Yeah.
Okay, and who's advertising there?
Oh, it is Cham Monty, I think.
Yep, Children's Hospital at Montefiore. Okay. So they've been advertising on the cover of every issue of Pediatrics for, I'm going to say it's got to be about 10 years now. I remember way back in my training seeing the ads for Monty on the cover of every one. I remember when it started. I remember when there weren't ads, and now there are ads, and it continues. I don't know how much that costs, but it's got to be a pretty penny. Why? Oh, and this is what I wanted to show you. So I dropped my kids off at school this morning. I was riding home, and then if you can see that, it's a giant, billboard near Penn Station. And I'll read the text for you. Beat 3 brain tumors at 57. Oh, sorry, beat 3 brain tumors, period. At 57, I gave birth again. Every day is a day to rise. And then there's Monty. Now that's got to be expensive. This is a giant hand-painted billboard across from Penn Station. What's
I
going,
haven't
what?
looked at those. I've actually seen them too recently. I noticed those.
Oh yeah.
Yeah.
So why is Monty advertising like it's selling sneakers? Like why is it like, it's like Nike trying to sell more sneakers than Adidas or whoever, right? McDonald's trying to sell more hamburgers than Burger King. Why is this going on? Why would a hospital have to advertise? I mean, if you need to go to the hospital, go to the hospital, right? Whatever one is nearest you, you would go to the hospital. Or if you are, training at Northwell, I assume you'd go to Northwell. Why bother advertising?
Because we live in a dystopian society where healthcare is a business, even if it's a nonprofit.
That's a great term to bring up. So all of those institutions that we mentioned are technically nonprofits, but that does not mean they are non-revenue generating. And we can put some numbers on it to sort of illustrate the magnitude of the situation here. So does anyone know what that number represents? You want to take a guess?
The revenue of healthcare.
So it's the economic cost of healthcare in the United States per year, not just a one-time expense. And when I made this slide about 5 years ago, the number was 3.3 trillion. Now, yeah, we can talk about COVID, but even before COVID, the last time I had updated it was 3.8 trillion. I mean, there's a trajectory going up, regardless of the extra blip of COVID. 4.1 trillion. Now, I have a question for you that sounds silly at first, but is this a lot of money? Or is it the right amount of money? Or is it not enough money? How are we going to be able to determine that?
I don't think it's about the amount, but more like what the effectiveness of what we use it for. So America spends more money than most other countries, but it's not very effective. We have pretty poor health outcomes.
So what are we getting for all this money that we're spending? Absolutely. And you talked about comparing to other countries. I'll give you a number. We spend, I think it's about $13,000 per person per year, if you break this out over the whole population. And there's no country that's, a perfect match for, comparing the US to something else. But if you look at Canada or the UK, they're spending something like $6,000 or $7,000 per person per year. So let's say roughly half. But then you also brought up the question of, okay, well, they're spending half the money per person, but what are they getting for that? So we don't have to guess, we can look at the data. And this is not the outcomes, but the percentage of GDP. So if you go way back to 1980, among these industrialized countries, the United States was at the top of the list, but still in the pack, as it were. And as the decades progressed, we broke away from the pack. And, this is 2018, it's 16.9%, 17% of our GDP was healthcare spending. It's gone up. I think it's about 18 or 19%. So not only has the absolute number gone up, the percentage has gone up. We spend a greater percentage of our GDP on healthcare, such that it's now 1/5 of our GDP. It's gone up to close to 20%. It's the largest single sector in our economy, everything they categorize as healthcare. So that's not just doctors and nurses in some kind of, child's view of the world. It includes insurance and all the administrators involved in every step of the processes, right? The pharmaceutical companies, et cetera. But that is the single largest sector of our economy. It employs about 1 out of 6 people who are employed. So 1/6 of all the people working are in the healthcare sector, generating 1/5 of our total economy. I'm just sort of painting a picture here. Let's go through some other numbers. How are we doing with that money? Well, we have the most adults with multiple chronic conditions. We have the highest obesity rate. This is preventable deaths. So each of these pairs here is looking at 2000 versus 2016. Now, for every country, the preventable deaths have gone down. That's great. But we're still winning within that comparison. We still have the most preventable deaths, right? Our 2016 preventable deaths are higher than the old preventable deaths for Switzerland and France and things like that, comparable to some of these other countries. So we have proportionally more preventable death, and it's happening. It continues to happen. People continue to die unnecessarily in this country. How about something as basic as life expectancy? So going back to 1980, again, we were in the pack. And then as we were spending more and more and more and more of our GDP on healthcare, how did we do? We started living less, not just relatively less, but our life expectancy has been decreasing. In the last 2 years, it has decreased further. So this is painting a bleak picture. We're spending the most money, absolutely. We're spending the most money proportionally and per capita, and we're getting the worst healthcare outcomes among all industrialized countries. Why? Why is that happening? What are you talking about? We're spending 4.1 trillion, $13,000 per person per year, and we're doing terribly. Why would that be the case? Any hypotheses? Any guesses?
We have a lot of other, I think it's a combination of things. Like, number one, our healthcare system is like a capitalist-based system, so it runs very differently than a lot of other industrialized countries. So we're spending a lot of money, and it's just like more complicated. I think we have insurance involved, things like administrative costs, but also we have a lot of social factors that are worse here. Like, I think a couple of years ago, like the WHO, when they came and like assessed different countries, said parts of America are like developing countries, depending where you are. So we don't have good environmental and social foundations to prevent like the development of a lot of chronic diseases.
I think those are all relevant points you brought up. The way I summarize it, this is my editorial here, is that we depend on disease to run our economy. Right? We'd be losing an entire 1/5 of our GDP if we prevented all this disease. And I'm not saying that it actually is a conspiracy from the Illuminati and the alien races trying to defeat us. I'm saying that it's sort of the state of the systems that have developed over decades and I guess a couple centuries in this country. Here we are. This is our system. We produce drowning children. That's the way we've designed our system. We will have disease and death. Go ahead.
Do you know how our revenue compares to how much we spend? Like, are we actually, like, how much are we getting net compared to how much we spend? Like, is it really, are we making that much off of it if we account for the amount of money we spend on it?
That's a great question. I can't answer it because what I think you're referring to is sort of you have to acknowledge externalized costs. So if you're saying that we generate $4.1 trillion of our economy, right? How much money are we putting in to generate that 4.1 trillion? And then on the other side, you're sort of alluding to, well, are we actually really getting $4.1 trillion there, or are we losing some of that as if it's a gross? And then what's the net when we account for all of the other sort of costs to the entire country? I can't answer that. I don't know. But this idea of externalized costs, like the health insurer, they're making X profit, right? The hospital system is making X profit, but where is their profit being matched and maybe overcome by losses in other sectors? I don't know. Great question though. What we can look at in a more simple view is where that money is being spent, the 4.1 trillion. So this is from a Health and Human Services report, and I'll send you the links to the documents after we're done. But 97% of all that 4.1 trillion is spent on what we'd call clinical care. The public health, I would even take issue with this. I think this 3% actually goes on this side as well, because they're including here preventive services like screening for mammographies, mammography screening and colonoscopies, things like that. Now, is a colonoscopy, is that what we'd call primary prevention? I don't know if you're familiar with these public health terms, but do you know the difference between primary and secondary prevention? So primary prevention is intervening absolutely before there's any disease. So a classic example would be a vaccination. You are totally healthy and fine. You've just intervened by injecting something into my arm. Why would you do that? Well, because we don't want you to get sick. We're acting now before you're sick, so you don't get sick. How is that different from a colonoscopy?
Like you might already have something, so you're just screening to see if you do.
You're screening for the early stage of a disease that's already occurred. Same with mammography, same with any screening, right? With your screening, you're looking for the early stage of something. You're not preventing in the primary sense, you're secondarily preventing the progression of a disease. And there's tertiary prevention as well. After a disease is more fulminant, you want to be able to mitigate the severity of the consequences. So anyway, however you slice it, the vast majority, if not all, of that 4.1 trillion is on the clinical care side. So with everything we've talked about in terms of our outcomes and how we compare to other countries and the absolute costs to society, et cetera, I would say that this is unbalanced. But I think there's some hope here, because we know that there is huge leverage on the public health side. And it depends on which analysis you read, but estimates vary from like spending $1 on public health could save you like $4 over here, to like $1 could save you $20, $30 over here. And I think that's, Caitlin, accounting for the externalized costs, like which externalized costs are you actually accounting for? But let's take something relatively conservative, like spend $1, you save $5 over here. What would happen if you move just a little bit, right? I'm not saying eradicate our disease-based economy, but just tweak it a little bit, right? Maybe just spend 10% over here. If you move 10% of that money over here, you'd be saving way over $1 trillion per year. The absolute cost to the system would drop. So let's just say you saved $1 trillion every year. What could you do with $1 trillion extra? What other problems are that we would want to work on in this country?
I think most important things are generally like poverty and education. Like we have a lot
Sure.
of inequities that start from a very early point in life that will affect people downstream. And if we address those issues, we could probably prevent a lot of like diseases, improve our economy by having people who are all like actually educated and able to work and, be a part of the cycle of our economy.
So Caitlin's suggesting that we might want to work on poverty and early childhood education. Sarah, anything that you want to work on besides the healthcare stuff?
Oh, well, I was going to say like better access to mental health care and
Okay.
counselors, therapists.
How could we go even further upstream, though, than having to deal with all this mental health stuff that occurs? What kinds of things might we want to work on to prevent, truly prevent those mental health issues from happening?
Well, I guess a big factor is unemployment.
So let's just stay with that. Let's just work on jobs. Let's do job creation, job training. Okay, so that's your proposal. Chris, what are you thinking about? What other problems are there in the world or in this country that we should work on?
I think specifically like nutrition is like a big problem in the United States. I mean, we have the highest rates of like childhood obesity in like any developed country. So I feel like that alone kind of displays that.
So I'm going to modify that a little bit and let's just talk about food security, having food for some people who don't have regular access to enough quantity of food and enough quantity without all the added sugar that leads to obesity. So we have poverty, early childhood education, employment, and food security. And now we've got an extra $1 trillion a year. So we're going to greenlight Chris's proposal and Sarah's proposal and Caitlin's proposal. We can do so much with $1 trillion extra per year, right? How about all those hypothetical people we've put out of work because we've suddenly pulled the rug out a little bit from a disease-based economy, right? We're going to have fewer administrators in that sector, in theory. So let's retrain them, right? There's the employment angle for Sarah. Create new jobs. How about a universal basic income? If you've heard of that, right? That sounds like purely like if you're a critic, you'd say that's absolute welfare state. You're just giving money to people without any obligation. Yeah, that's exactly what it is. And we'll talk a little bit more about that in a minute. So I want to end with this second public health model. So we talked about the upstream downstream parable, right? It just sort of gives us a really simple view of, hey, there's bad things happening, but there was a cause for those bad things happening. And we sort of mapped it analogously to our US healthcare system. We let bad things happen and we put all this money into treating it. And we generate all this revenue, but the outcomes are horrible. Like there's a lot of kids drowning despite our expertise. You know, we've gone all in on saving drowning children, but we still have plenty who are drowning and dying. All right, so this is a model developed by someone named Tom Frieden. If any of you are public health nerds, I don't know if you recognize his name from, he used to be the director of the CDC during the Obama era. That was after he was commissioner of health for New York City. And I think he's working at an NGO now, working on heart disease globally, which is the #1 cause of death in the world and in the United States. Regardless, I don't mention him just because he's a guru of sorts in public health, but because he developed this, he codified this model, which is predictive, right? Models exist to predict for us, but they're only as useful as their efficacy in predicting. And this one tends to work really well. It's hard to find an example where this one wouldn't predict what actually happened in real life. So let's talk about it a little bit. So it has these 5 tiers to the triangle. And at the top, we have education. And we're going to run through this imagining that someone tapped you on the shoulder. You're done with your training. You finished your residency. Let's say you went on to a fellowship. Let's say you did an MPH along the way. And now you are an expert healthcare professional. You are prepared to solve so many different problems in the world. So someone from the Department of Health for New York State taps you on the shoulder. Thank goodness you're done. We need you. You're just the person for the job because we've got a new epidemic of tooth decay across the state. Can you help us come up with a list of possible things we could do about it? And you say, yeah, no problem. I got my triangle here. So let's talk about how we could do an intervention at each level. And then ultimately, once we've mapped the interventions, we can choose the one that's likely to be most effective. That's the whole point. So education is as simple as it sounds. it's assuming there's some kind of knowledge gap. You're going to fill in that knowledge gap with a message. So what could you do to educate people regarding their dental health?
So if we're talking like pediatrics,
Sure.
as long as you know the health literacy level of the family or what their preferred way of like learning is in terms of like reading, pictures, whatever, providing like education on expectations for brushing your teeth, flossing, going to the dentist, just giving them like the basics of what they should be doing and making sure they understand it.
And you're trying to sort of acknowledge the limitations already, right? You're sort of saying, well, we have to understand their literacy level and maybe cultural competency and expectations and the relationship you have with them. Yes, all those things come into play, and they actually represent potential barriers to them hearing what should be a simple message of brush your teeth. That's why I put it in quotes, because all you're doing is saying something at this level. It could be handing out a piece of paper, or it could be saying it verbally, but you're just getting these words, brush your teeth. That's it. Nothing else has happened. All you've said is brush your teeth. End of intervention. Now, moving to the clinical level, this deserves a little bit of definition. When we say clinical in, everyday professional life, or even outside the medical profession, we're usually talking about something involving doctors, or maybe it takes place in a clinic or a hospital, or maybe there's a medication involved. That's not what we mean here. Clinical in this definition is simply moving from information to action. And that action has to be performed by every individual in the population you're talking about. It has to be performed repeatedly with no predetermined endpoint. So every person has to do something every day for the rest of their lives, basically. That's what we mean by clinical intervention. So what would be the correlate to brush your teeth for every individual doing something every day for the rest of their lives? It's exactly as simple as you think it is.
Like actually brushing their teeth.
That's it. And I know this sounds simplistic, right? We're going beyond simple to simplistic. Yes, because I think that illustrates the deficiencies in utilizing some of these interventions. All you've done is you've told someone to brush their teeth. That's the end of the intervention. What you hope, your big aspiration, is that person goes home and then brushes their teeth every day for the rest of their life. And because you are dealing with population level health disparities, it's not about that one person, it's about every individual in the entire population. You have to tell each one of them, they have to listen, they have to understand, they have to care, they have to prioritize, they have to go home and actually do it despite what other things are going on in their lives in order for these things to be successful. You've suddenly put all of your money, you're saying, I'm all in on education and clinical. Is that bet going to pay off? Well, let's talk a little bit more about some of these other levels. Okay, moving to one-time long-lasting. Instead of a repeated action, it's something you do only once or very infrequently. So what's something you can do that a person can do that would protect their teeth for, let's say, years? They do it once, but they get maybe a matter of years of protection from tooth decay.
Like sticking to their dentist appointments.
So you go to the dentist, okay? Let's say you walk in the door of the dentist, and I know this sounds pedantic, but let's just be clear about what we're actually saying. You go to the dentist, you walk in the door, you sit in the waiting room, and then the dentist actually has an emergency, has to leave. And so you say, oh, well, and then you leave. You've gone to the dentist. Did anything happen? No. So what do you mean when you say go to the dentist?
Like actually be seen by a
Okay.
dentist.
And then what happens?
Cleaning.
So the dentist,
them.
okay, cleaning. All right. So yes, in that if you scrape off all the plaque, it's going to be better than not having that plaque. I mean, it's going to be better than having the plaque on your teeth. But how long does the protection from that last, really? I mean, I know it's, you know, the appointment's every 6 months, but the actual plaque that was removed, how long does that last? I was talking to one dental colleague of mine. They're saying, well, okay, yeah, maybe there's like a week of protection. So yeah, it's not something you'd have to do every day if you're going to rely on that to protect your teeth from decay. But is there something else we could do that provides even longer lasting protection?
Fluoride treatments that they give.
So like a fluoride varnish, right? So a fluoride varnish, that's even longer. Maybe there's like a year of protection from that, maybe. And then something that lasts even longer, something you've all had done to your teeth likely when you were an adolescent and you had all your adult teeth in, is a sealant. So like a fluoride varnish, which is applied to the teeth, the sealant is also a chemical compound applied to the molar surfaces, and it provides a physical barrier protecting the teeth from decay. And that can last, 5 years, let's say. So let's just put that in as an example. Sealant, that sounds great. What would prevent everybody in your population from actually getting this sealant applied to their teeth? What are some of the barriers?
Well, I remember that they did this in a lot of schools growing up. So I guess like not going to school or not having like
Okay.
enough like public school that would afford this, I guess.
Okay. What if it's not happening in a school, but you actually have to?
Yeah, it didn't happen in schools in Philly, and I never heard of this, so I don't know if I've had it or not. But I know at least with fluoride treatments as like an adult, it costs money. Like insurance doesn't
Money,
cover it,
insurance.
so insurance might not cover it, and then you have to pay out of pocket. Or if you don't know about it, you might not know if your dentist is doing it or not. They might not say anything, or they might not offer it, and you don't know to ask.
So you have to have insurance or some other form of payment. You have to sort of at the top know that it exists and maybe request it. How about transportation to the dentist? How about pulling your kids out of school? Are you taking time off work, right? All of these things, these 3 top tiers, are all putting the burden, as it says on the side here, on the individual. Every individual has their own burden to bear when you're relying on these 3 categories. So even if you hear the message and you care and you believe the person telling you the message, and even if you want to brush your teeth, you're going to have to be a perfect agent and brush your teeth, twice a day, every day for the rest of your life. And even if you want to get a sealant, you're going to have the money and the transportation and the time. The Swiss cheese model of medical errors, right? All these bad things have to line up for the error to actually occur, right? You're relying on a Swiss cheese model of medical success here. All these things have to line up, not just for one person, for every person. And we're talking about New York State. You're the czar of tooth decay for New York State. That's millions of people. And you're depending on the Swiss cheese lining up for all of these people for these strategies to work at a population level. Okay, so I put this dotted line in here, which is not in the original diagram. And I'll send you the link to the paper if you want to look at it. It's actually well written and pretty short. So it's a nice thing to have in your pocket. I put the dotted line in here to really emphasize that distinction from burdening the individual, instead burdening society, so that individuals don't have to take action per se. So what's something we do, when we talk about changing the context, what is something we do that default protects an entire population without them even knowing that any intervention is going on. How do we do that to protect teeth? It's considered one of the classic success stories of public health in the 20th century.
Fluoride in the water.
Bingo. So why is that different than anything at the above tiers?
People don't even have, like, people don't know fluoride is in their water even
Right.
necessarily. Like, there's no education. No one needs to understand. No one needs to be told anything or to do anything. It's just using the water that they're already using.
Using the water they're already using. We're making the assumption that people do consume water in some form on some regular basis at some quantity. So if you wake up in the morning in New York City and you decide to get your coffee or tea, maybe you make it home, maybe you go to a coffee shop, get it on the street corner from a vendor, whatever. What water has been used? It's been New York City tap water. You've gotten your fluoride. If you go out to eat or make food at home, you're cooking rice or pasta, the water's tap water. You've gotten your fluoride. So it's not adding anything to your life. It's not asking you to do anything that you're not already doing. But everybody in the population gets the benefit. That's changing the context. You've flipped the burden. Society has said, we're going to take on the burden of fluoridating the water and maintaining this water system so that everyone gets the benefit by default. Now, let's say you were a conspiracy theorist. I'm not going to drink that fluoride. That's how they get you. So what would you have to do to live your life according to your values and beliefs? Chris, are you saying something?
Oh yes, sorry, I'm muted. Like not use tap water ever to like drink, essentially.
So yeah, what would you use instead of tap water?
Like bottled water.
Yeah, bottled water. Now we can go off, we won't do it, but I could give you an entire separate lecture on bottled water versus tap water. Tap water in New York City, as just, the quintessential example, it's the highest quality in the world. And I know that sounds hyperbolic. To be honest, there is no single best water in the world. That's ridiculous. But among the highest quality municipal water systems in the world, New York City is right up there. There is none better. It's in the top tier category. And one of the things that makes it good is that it has fluoride in it. So in New York City, everyone's getting the benefit. So if you want to avoid the benefit and drink only bottled water, you're going to have to do that for every single circumstance. You couldn't go out to eat in a restaurant and order anything that was prepared with water because that would be coming from the tap. So you've perversely created a clinical scenario for you to avoid the benefit, right? You'd have to take the burden back upon yourself and use bottled water in every instance for the rest of your life to avoid the benefit. That's the power of changing the context. And it does bring up a saying that might pique your interest, a public health mantra, perhaps. Every successful public health intervention is a compromise of civil liberties. And this is a great example, right? I didn't ask for fluoride in my water. You're forcing something on me. You're taking away my right to choose. Yeah. That's why not every community has fluoride in their water, right? If you're in Long Island, none of the municipalities have fluoride in their water. I mean, there are various reasons for that. I don't understand the complexities, partly because it's such a fractured system. Each city, township, what have you, it's a real patchwork of water supplies and water systems. So, but it turns out that zero, as far as I understand, zero residents of Long Island have fluoride in their water. Hence, you have to lean on the fluoride varnishes, for example, and fluoridated toothpaste. All right, so let's wrap this up by talking about the bottom tier of the triangle. Now, you as the tooth decay czar of New York State, you know that you could tell people to brush their teeth. You know that you want people to brush their teeth at home. You want people to go to the dentist, get a sealant. You want to convince every municipality to fluoridate the water. But even if you did all of those things, a huge accomplishment, we wouldn't get rid of tooth decay 100%. And especially when we reduce the absolute level of tooth decay, we'd start revealing the disparities that might have been hidden before. So why do these people still have high rates of tooth decay when these people went down? That's when we talk about socioeconomic factors, the most upstream we can get. So what are some of these socioeconomic factors? The way I like to think, I mean, different people have different definitions, but I think the most useful in this model is to think about capital, financial capital and social capital. So financial capital obviously includes money, your wealth, but that also quickly correlates with the quality of your housing, food security, the quality of your early childhood education. And then on the social capital side, we can talk about things like racism, political empowerment, right? Enfranchisement, you know, ability to have a political voice by voting, things like that. So if we're not addressing the disparities in those fundamental SDH factors, it's like the broken bridge. We are going to predict bad things happening to the people in those circumstances. It won't be a surprise. It will be absolutely predictable. These people will have higher rates of not just tooth decay, but obesity, diabetes, hypertension, and substance abuse, and mental health disorders, and teen pregnancy, and poor school performance, and poor lifetime earnings. It all goes together based on these predictable factors from the outset. So I put it to you, what's something we could do to change these circumstances at the most fundamental level? What's an intervention we could try? Even if it sounds implausible or outrageous, what could we do?
Universal income.
So I talked about UBI, right? And I said we'd mention it again. Universal basic income means giving people, so universal means everyone gets it. Basic means it's enough to get you out of poverty. And income means that it's occurring on a regular basis, UBI. There's a state where this is already happening, although I wouldn't call it up to the level of basic. So it's not really getting people out of poverty, but it is universal and it is regular, except only on a yearly basis. But there's a state where this is happening, and it's not a blue state. It is a quite predictably red state. Anyone want to guess? I'll give you a hint. It's because of their particularly small population and relatively high wealth from the major source of their economy.
Vermont.
Good guess, but that is a determinedly blue state. We're talking about a red state, and it's not New Hampshire. I know that tends to be a little bit more purple. Rhode Island?
Yeah,
Is that what you said?
small.
They tend to be, they're definitely small, but they tend to be very blue.
About like Idaho.
You're getting closer geographically and
Utah?
culturally. Say it again?
Utah,
Nope. I'll just tell you, Alaska.
they're red.
Oh yeah.
I would not have expected that. That was my first thought, but then I was like, oh wait, I feel like they're Democratic now.
Well, why do they have relative wealth? Where's the money coming from?
Oil.
Oil. And basically nobody lives in Alaska. So they've got all this oil revenue, and they basically give you a yearly dividend from the state to be a resident of Alaska. Now, it's not really that much. It might be, under $1,000 per year. So it really hasn't been shown to change health outcomes, right? It's just not enough to reach the threshold. But it's an interesting sort of pilot for what's going on in other places. So in New York City, in East Harlem in particular, there's a pilot funded by a foundation that gives families, they're in cohorts, right? One family, one set gets $500 a month for, I think, maybe 3 years. Another gets $1,000 per month for 3 years. And then, of course, we have the controls of people not getting any money at all. So at the end of 3 years, we'll see how well did these people do, relatively speaking. If they're all coming from the same, basically, poverty level, they're all families with small children, how did they do? How did those children do, right? So if you're going from, let's say your income is like $12,000 a year, you're living in poverty, and you suddenly double it to 24,000. Are you suddenly able to not worry about food security because you know you have money for groceries, right? And so you don't have to decide between rent and groceries on any given month. How does that change your life? It could make a huge impact. That's the hypothesis. Anyway, so UBI would be an example of a socioeconomic factor intervention at the bottom of the triangle. So I think we'll leave off there. Thank you for your patience, but we'll pick up with this triangle again when we resume next week. And we can talk about mapping, asthma interventions to it, just so we can give it some more practical context, right? Because you are not dentists, but you will be seeing asthma, unfortunately, too much. Those will be the drowning children. Among the drowning children you'll be saving are plenty of who have asthma. So we'll talk about how we could map interventions to this triangle and try to do the most good with the precious few public health dollars that we have. So thanks for your attention. I'll send you the wrap up and link to this recording, and see you next week.
Thanks.
Thank you.
Take care. Enjoy.